So, Dr. Vierling is a tenured professor of medicine and surgery and chief of hepatology at the Baylor College of Medicine in Houston, Texas. He's also director of Advanced Liver Therapies, a clinical research center devoted to the study of liver diseases, and program director of Transplant Hepatology Fellowship. He obtained his undergraduate degree in biology with great distinction and departmental honors from Stanford University, and his medical degree from Stanford University of Medicine. In preparing for this introduction, I discovered that his internship was done at Strong Memorial Hospital, which is in my hometown of Rochester, New York. So I'm very glad. I hope he enjoyed his time in Rochester. He is an ABIM certified in internal medicine, gastroenterology, and transplant hepatology. His clinical interests include autoimmune liver diseases, viral hepatitis, liver transplantation, metabolic and genetic diseases, acute liver failure, and drug-induced liver injury. He has authored over 250 manuscripts, reviews, and chapters on these subjects. His honors include Pi Beta Kappa, Alpha Omega Alpha, Best Doctors in America, Top 1% Physician Rating by the U.S. News and World Report, Who's Who in America, Who's Who in Science and Engineering, and Who's Who in Healthcare. He has served as president of the American Association for the Study of Liver Diseases, secretary-treasurer of the Digestive Disease Week, and chairman of the National Board of Directors of the American Liver Foundation. He has been with our organization since its early days. Most recently, he played a big part in getting the name changed to primary biliary cholangitis. And he was a part of the group presenting information at the FDA Advisory Committee on, I'm still calling it obeticholic acid because I can't pronounce the new name. And it's my privilege to introduce Dr. Vierling.
Well, Carol ate up all my time with the introduction. I appreciate that. I had to pinch myself. It sounded more like a eulogy, but I'm glad I'm still alive. It's a real pleasure to be with you again, and it's quite a remarkable journey for all of you who have been afflicted with this and have suffered with a situation in which we introduced off-label therapy with ursodeoxycholic acid around the late 1980s for some of us and early 1990s for the majority of the world, because we were able to see the publications that were coming out of Raoul Poupon from France and Montreal, and then subsequently Jenny Heathcote in Toronto and Keith Lindor at the Mayo Clinic. And although it wasn't until Scandapharm took it upon themselves to actually seek an FDA indication for the treatment of primary biliary cholangitis, and were authorized in 1997, that we actually had this. So we actually go back about 35 years in having only one therapy, one size fits all. Not everyone able to tolerate it, but thankfully that was only about 3%, 5% worldwide. But people that responded beautifully and people that responded partially. And that was our landscape. But much has been achieved now because we now have a new name and we have new therapy. And I'd like to take you through some of the highlights of this and leave adequate time at the end for questions. So we're going to go to the overview of all of this. And you're all aware, because you heard this yesterday, about genetics and environment from Eric Gershwin, that something corresponds at an appropriate time in a susceptible individual to lead to a loss of tolerance to this very specific component of an incredibly important enzyme complex. And that PDCE2 is expressed on the inner membranes of mitochondria. So when they put serum down on cut sections of cells, it stained the inner membrane of mitochondria. That's why they called it anti-mitochondrial antibody, or AMA. But we now know it's actually its molecular structure. We know that that is then followed by T lymphocytes. We have B cells that make a lot of antibodies, and we have T cells that help them make antibodies and do other things to protect us against our environment. Those cells become autoreactive, and they start to attack the lining cells of the bile ducts. But it's not just any lining cell. It's only the lining cells of the small to medium caliber ducts. So if you think of your biliary tract as my hand, and these are the radicals, and the outside here is your liver, and down here is your common bile duct, where it all pools and then goes into your intestine. We're talking about only the bile ducts right out at the tips here, what we call the most proximal, because they're proximal, this would be distal. So it's just these caliber bile ducts. And that gave us a hint that there's something about those cells that must be recognized. Well, we took that a lot further, and I won't bore you with this, but it turns out that that process is identical to the process of what happens when you transplant a liver into anyone and they get rejection. The immune system targets those bile ducts with exactly the same pathology. And if you undergo a bone marrow transplant and you get what's called graft versus host disease, the component in the liver is identical to this. So we know the immune system is somehow inherently able, not just with autoimmunity, but with graft rejection of a transplant or graft versus host disease, to actually target those ducts. We don't know why. And if we figure that out, we could probably stop that process. That's why I want to spend a little moment on this, because it's still a hot topic for investigation. But when these things are so inflamed, they give up the ghost and die, and those little bile ducts are blocked. Well, that means that the plumbing system is now blocked, and so you block your plumbing system on your first floor. That's backed up on your second floor and your third floor. And it's all those areas trying to drain their bile through those individual ducts that get backed up, and we call that cholestasis. Cola just means bile, and stasis means stasis, so it's stasis of your bile. It can't get out of these destroyed areas. Now, with time, this causes fibrosis to occur. Fibrosis is just a fancy word for scarring. And as scarring ensues, the scar can lead out to such dense scarring that it traps liver cells. And when liver cells are trapped, not getting all the rich blood supply they once had because of this scar formation in posing itself in their pathways of blood supply, they start to divide, because liver can regenerate. It's the only organ in your body that can regenerate. And when they regenerate, they push out against the scar, and so you end up with nodules of regenerating cells with scar. And that's what a pathologist calls cirrhosis. That is the word cirrhosis. So cirrhosis is not mysterious, and it's not an endpoint. We like to have people know that very clearly. Cirrhosis is a process. If you have cirrhosis and it's early on, and we're successful in retarding or stopping the underlying mechanism of cell death and injury, then you won't replace functional cells with scar. It's the ongoing process of cell death and replacement that is the progression of cirrhosis. So cirrhosis is not an endpoint. And I can't imagine that a more important message to people who may have that histologic stage. You can lock in excellent prognosis, survival, function, longevity, all by stopping the process when it's early. And this is something that you all need to know. Now, when we get down to those that progress without treatment, and there's no one with this disease that should go undiagnosed in this era or be untreated, then we can get into the terminal stages of liver dysfunction. We've lost the function. We've built up a lot of pressure trying to flow through the scar, and that back pressure causes other things to develop. And I think that Victor and Comase went over some of those things of what constitutes sort of an advanced state. And then we end up here with the potential for liver-related death. Well, that's the bad news. That's what was happening without therapy. But we've changed it starting about 35 years ago, and now we have ways to change it even further. Now, we know on this graph, and I want to orient you to the graphs, because for us, you know, graphs are just our our currency. For all of you, you look at it and say, what the hell is he talking about? And we just want to be very clear. This is looking at what's called event-free. Now, you can say event-free might be the deterioration to that really bad state of disease, or the need for a transplant, or a transplant itself, or a death for any cause. That's what we mean. And if you had free of death, you would be right up here, free of any event. This is time in years. You see, that's 15 years. And what you see here is that from this Dutch study, the general population over 15 years will actually have events. We are all mortal. And depending upon your age and your sex and your underlying health issues, some people are going to have any number of events. So it happens. Now, if you look here, these are patients who began treatment in the early stage of their diseases. And they're very similar here. These are people that began treatment in the late stage, and these were people that began treatment where they were really one step away from that very advanced failure state. So what this tells you is it's a call to all of us and a call to all of you to reach out around the world to have people recognize that they might be at risk, get diagnosed early. We get diagnosed early, we can do something about it. That's what these graphics show. So what about the name change? Well, this will go rapidly because you've been through this a couple of times in the last few years, and I'm very pleased that we were able as an international community, with your help for sure, to have this change be so nicely accepted. You know it's inaccurate for the majority of patients without cirrhosis because the majority are diagnosed before cirrhosis. So why call it primary biliary cirrhosis? It has negative connotations. I'm sure that you face that in your as a patient and with your family, and I've seen a lot of people nodding at that as I'm looking out here at the audience. We know that lay people associate this with alcoholic liver disease. And it's kind of not their fault. It's the only thing they learned, and they are not educated. And they may be very educated in their professional careers, but they're not educated about the liver. And then they think, well, if it's not that, it must be hepatitis B or C. And if it's not that, it associates with a terminal prognosis. So this is a person, we say it's nice to have known you, and we kind of disengage. And I'll bet you have experienced some things like that. And then it's a disincentive for private support for education and research. Why put your eggs in a basket where everybody is on their way out? Because everybody has been said by the name of the disease, it's cirrhosis. Well, there's high level of support for the name change. You know all about that. And there was no support for the status quo. But the key goals were important because we wanted to remove the stigma with the word cirrhosis, and we want to retain the abbreviation PBC. And so we were able to do that. And here is one of 6 concurrent publications in every major journal involved in gastroenterology and hepatology, the study of the liver. This is the one from hepatology, changing the nomenclature to cholangitis. So it's now primary biliary cholangitis. I'm very happy to have joined Raul Pucon in a senior authorship role here. And here you see a lot of your people that you know and have heard in this forum. Eric Gershwin, you heard from yesterday. Keith Lindor has spoken many, many times. And you have an array of people here that represent the entire globe. So we have Japan, China, Australia, Europe, former Soviet Union. Everybody has got a representation. So this has now occurred, and I think that all of you need to disseminate this because we no longer want to use the term primary biliary cirrhosis. It is now primary biliary cholangitis. You will see it in every publication that's coming out. You will see it in all international fora and meetings, and we have changed the name. Now, there's a little work to do to get it into the computer systems, which is WHO's ICD nomenclature, but we're working on that, and it's going to happen. But if we change it operationally, we've won. Now, let's get back to the disease and its therapy, and this is based on the therapy of ursodeoxycholic acid. I'm going to call it UDCA in a couple of the slides, so just know it's urso. And this comes from the long-term data out of France, Coprechaud with Pupon's group.
Now you look at the probability of transplant-free survival. Well, if you have 100% probability of survival, you transplant-free, and it means you also have no all-cause death, cardiovascular, cancer, anything else. And if you had no survival, or everybody underwent a transplant, you'd be down here. Here's 15 years again. Here's the majority of PBC patients treated with URSA. And that's this little step-down line. Well, what's this little dotted line? That's the French population of age and sex matched people for the people that were in the PBC group. Do you see a difference? I don't see a difference. That means the majority of people that were treated with URSA 15 years later are living just as long as the normal population does in France. That is really excellent. But what about this group, the minority? We see that starting fairly early on, they're trending down, and although they are a minority, they are at great risk of progression of their disease and transplantation. So just keep that thought in mind, because I'm going to add a few details to it. But before we get there, we have to say, how would you know somebody, rather than following for 15 years when you'd know for sure for the individual, how do you know right now how somebody's doing? How can you project whether they're going to be in that majority or minority? And that's where we get into this wonderful global PBC study group. Now, this was a very, very important group. It remains that. It is 15 centers around the world, and they have pooled all of their data. They are currently up over 6,000 patients for an orphan disease. That is a tremendous number. And they're involved in a number of things, but when they analyzed their data, they found that when you look at the hazard ratios, meaning the risk above a fixed risk of 1, meaning that there's no risk at all, or 0, I'm sorry, that you saw that for alkaline phosphatase, that there was a rise in risk, and you saw it the same thing for bilirubin. And if you looked at bilirubin in particular, you saw that even within the normal range, which goes up to about 1, that you come down for every little decrement that you got, you actually were surviving better. This one showed a little bit of the same thing, but it was a little bit more horizontal. And you do the math, and it turns out that the best indicator of whether you were in that majority surviving like the rest of the population was whether your ALK phos fell beneath 1.67 times the upper limit of normal. So why do we do that? The reason is that all the labs around the world and in this country have a variable level for what's the upper limit of normal. A couple of you have talked about your liver tests to me already this morning, and if you look at your normal range, what you need to do is multiply it times 1.67, and that tells you what your goal would be to be underneath that. So any normal range can be translated using this. So this told us that these were the parameters that were important. Then we started to look and say, okay, do they project over the 15 years survival? Are they the ones that we can look at and tell a patient you're going to do well or not? And we found that if your ALK phos was at or beneath 1.6 times the upper limit of normal, you had this survivorship. And remember, even the normal population is going down somewhat. You saw that before, right? So down is being human. But if you were above that, you had lesser survival. And the same thing was true of bilirubin. If you were within the normal range, up to essentially 1 milligrams per deciliter, versus above that range over 15 years. So this and that independently were markers for that survival at any given time. Now, if you put those together, they actually were even more powerful. Here we have the global PBC group, nearly 4,900 patients. Here we have an independent group in the United Kingdom where every hospital in their nationalized health system has to enroll patients with this diagnosis for analysis. So 2 independent studies, huge numbers in comparison to the disease burden in any individual country. And obviously, to get these numbers, they were in part predicated on the fact that for 35 years, we've been treating people with URSO, and the majority of them are doing really well. So they're all alive. So instead of having a few 100,000 people, we have multiple thousands of people that are alive and well. It's kind of a testimony, if you will. Now, here's 15 years again. Here's survival, 100% survival, no survival. You look at normal bilirubin and composited with the alk phos dropping versus normal bilirubin with the alk phos above 1.67. You see those two lines are similar, but they are different. You do less well if you're above the 1.67. If you're abnormal bilirubin, you still are doing better if you get your alk phos lower than 1.67 than you do if it's above. And the same kind of displays were seen in the UK, basically validating it. So you can end up with a composite endpoint. You can use both alk phos and bilirubin. Now, I want to share this with you because it's going to be an important way in which physicians and patients are going to be able to take their individuality and express it as a score, doing well or not. This comes from the Global PBC group, and it's called the GLOBE score. Now, a GLOBE score of less than 30 has this prognosis compared to the normal non-disease population. Obviously, that's the prognosis that you want. A GLOBE score greater than 30 differs from the normal population. Now, this is a very complex equation, and it's about to get loaded up so you'll be able to Google it, go to a calculator, put in your own labs, and calculate your score. And it is going to be a score that is malleable. If you don't make the score with our new therapies and your willingness to participate in new and future clinical trials of even newer therapies, we ought to be able to move people into a different score. So it's not that you do your score once and say, I'm in trouble. It's that, I need to do better, is what I want you to be saying, and that's where the newer therapies will come into play. But this score is one I want you to be aware of, okay? Now, we have done well, and I told you that we were doing well with the majority of people. How do we know that happened in the U.S.? We don't have a national health system. But we know, and you heard yesterday from Victor and Comase, that early in transplantation, you go back into the 80s and 90s, that transplantation used to be dominated by primary biliary cholangitis. And then we've done less and less. Well, these are the national data to show that the number of additions to the transplant waiting lists from 1995 through 2016 have plummeted for PBC. That's the testimony in the U.S. that URSO is working for the vast majority of people. They're not needing transplantations. They're not going onto the waiting list. Now, I could show you data about hospital admissions. It's also down in the U.S. I could show you data about having it listed as a cause of death way down in the U.S. People are living, and if we're all mortal, we're going to die of something, but it's not going to be a liver-related death. So we have credible evidence in the United States of what I've been showing you from Europe. That's the good news. The bad news is right here, that we have a very conservative estimate in the U.S. I think it's an underestimate, but let's use it, because the reference point is that we have existing at this moment in time 128,000. I think it's closer to 250,000 to 300 personally, but whatever the number is, you can see that access to health care occurs in about 85 to 90% of that group in the U.S. The PBC diagnosis rate, however, look at that number. It's about a third, a little over a third. So 2/3 of people are not sort of getting diagnosed. Under care, drops again, and being treated with a therapy that the majority will respond to is only about 43. So you can do the math on that, but the bottom line here is that we have an educational problem for physicians, healthcare providers, and patients, where you can help with that, because no one out there should be running around with an abnormal alkaline phosphatase and having it not further investigated in the American healthcare system. Because our diagnosis can be made, as you know, can be made without a biopsy in those that have antimitochondrial antibody, which is going to be about 98% of people. So we need to make this diagnosis and start a treatment where the majority of people will respond to it. But we haven't been doing that. Now let's look at the ongoing unmet need. We know that if you use Barcelona criteria, developed obviously in Spain from Dr. Perez, you look at Paris criteria of Coprachot, you look at the Rotterdam criteria, the Paris II criteria, the Toronto criteria. These are the people, the percentages of people who didn't fall into that excellent majority response group. So short of tossing out the outlier here, you can see that we're right around 35–40%. Said another way, that we have somewhere in about 65% of individuals who are diagnosed and treated with URSO are going to go into that majority response. And somewhere between around a third may not. They'll have a partial response. They'll still march down that alkaline phosphatase curve, because lower is better. But below 1.67 times the upper limit normal is best. That's the unmet need, to get everybody, these 35–45%, into that category. So here comes obecticolic acid. Obecticolic acid is a synthesized derivative of our primary bile acid, which is called chenodeoxycholic acid. What a mouthful. I'm sure you're just writing down the chemical structure as I speak. I just could see it. Yeah. So I want you to look at the slide instead. Now, we abbreviate this OCA for obecticolic acid. And Ocaliva, OCA-leva, is the trade name of the new obecticolic acid. Now, chenodeoxycholic acid and obecticolic acid, there's an interesting story here. OCA and the development of this was done by Italian researchers as part of Intercept's development. So they made this chemical substitution. And when they did that, they called it obecticolic acid, and it's OCA for short. Now, OCA, oca, in Italian means goose. Okay, so it turns out that kino is Greek, and kino in Greek means goose. So I stand before you to give you a big goose about our new therapy, which is obecticolic acid. So what the heck is it? This, our normal bile acid that everybody has, is designed to interact with a farnesoid X receptor, FXR for short. That makes that receptor move from inside the cell to inside the nucleus, where it causes the genes to be expressed differently. It's called a nuclear receptor. And we're built to have nuclear receptors. We have to turn things on, turn things off. We have to respond to our environment. We have to respond to medications. This is how we do it. This is how we tell a cell what to do. So this is naturally there, but when you make this substitution, you actually increase its potency as causing that receptor to be activated 100-fold above